Before we get started, I would like to share a little bit of information on the CSOHIMSS chapter. First, if you would like to ask a question during any point within the webinar, please enter that question into the question feature box, which you can see if you open your control panel. You can just type in your question. At the end of the webinar, I will be reading all the questions to Mr. Scott. Handouts are available within the Handouts feature. You can grab them there, or you can go to the CSOHIMSS website and look under Events and Education, Past Events. All the handouts are available right now. Put them up this morning. We'll also be recording this session. It'll be available on the CSOHIMSS YouTube channel here in a few days. If you would like to get in contact with the CSOHIMSS chapter, our website can be found at csohio.himsschapter.org. You can also email csohio.president@himsschapter.org, which will go to our president, Mr. Jeff Haas. You can also email csohio.info@himsschapter.org, and that will go to several of our board members. We're also available on Facebook and Twitter. And on LinkedIn. The easiest way to find us on LinkedIn is just log in LinkedIn, search for CSOHIMSS, join the LinkedIn group. We could not do what we do without our sponsors. They are absolutely critical. They provide us with the funding we need to offer these webinars, as well as our fall and spring conference and our Ohio Health Information Technology Day at the State House. Our premier level sponsors are Cover My Meds, Malwarebytes, Signet Excel, EHR Integration. Our elite level sponsors are Metasource, ProLink Staffing, Tech Systems, Obix Perinatal Data Systems, Data Gravity, Redspin, also known as Auxilio, DMI, Time Warner Business Class, NTT Data, Excite Health Partners, Leidos, Winthrop, Centricom, ServiceNow, Direct Consulting Associates, CA Technologies, and Cisco. We do have several events coming up. Here in a few weeks, we will have our fall conference, which we title Holy Macra, It's Interoperate 2016. This will take place Friday, October 28th, down in the Kingsgate Marriott Conference Center at the University of Cincinnati. We're going to be talking about Macra and project management, revenue cycle. There's just kind of a broad array of topics that we'll cover during the day. You can register at the link below, or if you just go to the CSOHIMSS website, you can find the link under Events section. Don't forget to register for HIMSS 17. This year it's going to be February 19th to 23rd down in beautiful sunny Orlando, Florida. CSOHIMSS will be hosting a luncheon at HIMSS 17. We don't know if we're going to partner up with anybody yet. We don't know the date, but as soon as we know, we'll get this posted to our website and let all of our membership know. We do have our 10th annual Ohio Health Information Technology Day scheduled for Wednesday, April 5th. This will take place at the Ohio State House Atrium. Registration is not open yet. Keep an eye on our website. Also, we'd like you to save the date for our spring conference, Friday, May 12th. Don't know the topic yet, but we do know it's going to take place at the Conference Center at OCLC in Dublin, which is where we had our spring conference last year. We have a few more of these Lunch and Learn webinars currently scheduled. Next month, the topic's going to be the hidden enemy, malvertising and ransomware, presented by Brian Henger from Malwarebytes. December, our topic will be how can we enhance our end users' experience, a pragmatic approach to improving provider and clinical end user logon times, and this is going to be presented by John Flamon from Lockbridge. And I am working on the 2017 schedule. If you are interested in presenting on any healthcare IT related topic, let me know. I'll get you the needed information. There's a form we need to have filled out since we offer CEUs, and then we will get you on the schedule. All of our 2017 dates are open right now, but I have quite a few folks that are interested. So if you're interested, contact me immediately. My name is Scott Mash. A lot of y'all on this this webinar have my email. If you don't, just email the csohio.info@himschapter.org and someone will forward that along to me. With that, I am going to turn it over to our speaker here.
Okay, good afternoon, everyone, and welcome to what I hope will be a very informative lunch and learn. I'm sure everyone has heard probably a lot about the MACRA Act and MIPS and everything that you could think of that's going to happen in the next 90 days or so, and hopefully we will shed some light on that. We're going to do an overview of the provisions for the Medicare Access and Chip Authorization Act. We will identify the components of the CMS Quality Payment Program. We'll talk about the Merit-Based Incentive Program, the performance categories associated with it, the composite scoring, and then we will talk about the components of the advanced payment models and the qualifying criteria in the structure of those APMs. And of course, we will save some time at the end of this presentation, approximately 10 to 15 minutes to open up for questions. Next slide. I always am amazed at the number of acronyms that we use in the medical field, and just when I think we've maxed out, the federal government comes up with more, and it seems like we're in competition with each other. In fact, I had considered doing a paper using only acronyms to see if people could figure it out. You know, I would take my APM and make sure it's under my MIPS and, you know, go through my QPP and all these other good things. So I included a slide here with some of the acronyms for the terms that we're going to be using today or that you may see throughout the presentation. Next slide. As most of you know, on April 27th, the Department of Health and Human Services issued a notice of proposed rulemaking to implement key provisions of what we now know as MACRA. And the proposed rule implements the changes through a unified network called the Quality Payment Program, which includes two paths, and that is the Merit-Based Incentive Program, better known as MIPS, and of course the Alternative Payment Program, or Alternative Payment Models, better known as the APMs. Next slide. Now, the way Medicare looks at things currently, and they measure value and the quality of care provided by doctors and clinicians, there's a number of programs that they have sort of had together, meshed together, one of which was the Physician's Quality Reporting System. The other was the Value Modifier Program, and then you have the Medicare Electronic Health Record and Incentive Program. The intent of MACRA is to streamline all of those programs and bring them together under one umbrella. And they're going to use this new approach, obviously, for paying clinicians for quality and for the value that they provide for the payment system. Now, this is key when you think about MACRA, because everything about MACRA and MIPS has to do with moving us toward value-based reimbursement. And believe it or not, all of these different programs are connected. And as you see, if you take a step back and you look at population health and some of the other things that are going on in healthcare, it all boils down to one thing, and that is increasing the quality standards and the value-based reimbursement programs associated with Medicare, Medicaid, and getting paid. Next slide. Now, you might ask, well, when does all this start? So Medicare has decided that they're going to start measuring performance in January of 17. Now, to get there, there's quite a few things that have to happen. And that is, there's some steps you'll need to go through, which we'll cover a little later in the presentation. Even though the program starts in 17, January 1st, the payments will not actually happen until 2019 because there has to be a year's worth of data gathering in order to report back so that they can base the payments upon those items that have been collected. Small practices are going to be affected, and they're defining small practices as 15 or fewer clinicians. Practices in the rural health professional shortage areas, which is usually rural health communities. You're looking at physicians, physician's assistants, nurse practitioners, clinical specialists, and certified nurse anesthetists. This is just for the first reporting period. And there is a caveat to this, and it may be included in one of the other slides. But if not, I'll go ahead and mention it now, and that is, even though it's pointed at these practitioners in this particular area, if your Medicare population exceeds a certain percentage, you will also be qualified under MIPS. And I can tell you where to find that information a little later in the presentation. Next slide. CMS is thinking that a MIPS program should equip clinicians with the tools and incentives that focus on there's three things that everyone is talking about in healthcare today, and that is improving the quality of healthcare, increasing the efficiency in what it is we do and how we deliver the care, and improving and promoting patient safety. Now, the general thinking is that MIPS may increase, decrease, or not affect the clinician's Medicare payment rates for a year based on performance. And there are some caveats to that, and we can talk about that a little later. While I'm on the subject, I just wanted to say that even though we're putting a lot of emphasis on MACRA and MIPS, the actual regulation is still in the comment period. These are the proposed rules, but we're closing in on the final deadline, which is November 1st. So for those of you who do have comments but haven't taken the time to submit comments yet, you still have a bit of time. And I would encourage you to do that. And you can also go out to some of the different sites and you can see some of the comments that have already been submitted. Okay, next slide. Okay, MIPS allows the Medicare clinicians to be paid for providing high quality and efficient care. In order to do so, they're looking for good performance in the following areas. One is the resource and cost use, or resource use and cost rather, clinical practice improvement activities, quality, and advancing care information. And we're going to talk about each of these individually here. I'm not going to get into the detail of how the scores are calculated because that in itself could be a 3-hour-long webcast, and I'm sure none of you have time to do that, but I would encourage you, when you do have time, to take a look at the Federal Register or some of the other publications out there that explains how you actually will step through and accumulate the points. Next slide. So how are these points, or how are the percentages for each of these areas pulled together? Well, in the proposed rule, they're saying that the resource use and cost is going to account for 10% of the total score under MIPS. It will be a composite score in 2019. It's going to, or 2019, it'll be 15% in 2020 and max out at 30% in 2021. So it's going to be a graduated scale. Each year it's going to go up, and the percentage will become greater for this particular category. Next slide. So as I said earlier, it's going to count for 10% of the total score. It actually replaces the value modifier program that we now know and have used for a while. It's also known as the resource use. Okay, the score is based on Medicare claims that are submitted. So you don't really have to do anything to enroll or to report in this particular category. All of the information needed to calculate your score in this area will come from the claims that you submit. That brings up the question is that that many providers, or there are different providers with different specialties. So a few moments ago I took a peek just to see what some of the categories are, and there are categories, more than 4 episode-specific measures that will account for the differences among the different types of providers and the services that they provide, so, and their specialties. So, you know, for cardiology, you'll be under one set of rules or one set of episodes, and they're working on an episode grouper to match those. So if you were to go to cms.gov, you would be able to see some of that information. And I've been told that this particular grouper and how it works will be available in the final rule, which will be published November 1st. Next slide. Then we move on to clinical improvement activities. This is going to account for 15% of the total score, and it's still going to remain the same in 2019. At least that's what we know now. Could that change? It might in the final rule. Next slide. Okay, under clinical improvement activities, obviously accounts for 15% of the score in year 1. Clinicians would be rewarded for clinical practice improvement activities such as care coordination, beneficiary engagement, and patient safety. So what's care coordination? Care coordination is simply, if you are the primary physician, aligning yourself with other providers in a particular group that supports the care of the total care for that patient in that case. And of course, beneficiary management is engaging in those programs that get the beneficiaries involved in the patient health care and increasing quality. And patient safety is always paramount. Anything that you can do in that area, there are a number of examples in some of the documentation that's been published that talks about patient safety and how to do things that will increase that. One of which might be some type of medication alert or things of that nature. So it really doesn't take you outside your comfort zone. You just kind of have to think about some of the things you're already doing now or maybe doing in your practices. Okay, next slide. Clinicians may elect activities that match their particular practice. The goals from the list of more than 90 options, which will be published as well in the final rule, some of which I think you can find now. This additional credit will be awarded in this category for participating in alternative payment models, which we'll talk about in a little bit, and then the patient-centered medical home, which we will talk about in a little bit as well. I think we have that defined later in the presentation. And there's a caveat here, and that is clinicians that are participating in APMs, which are the advanced payment models, would be exempt from MIPS and the payment adjustments and would qualify for an additional 5% increase in their reimbursement on Medicare Part B in the incentive programs. And you'll see that as we talk more about the APMs later in the presentation. Next slide. We get to quality. Quality accounts for 50% of the total under MIPS in 2019, and then 45% in 2020, and 30% in 2021. Now, as I said earlier, these percentages could change, but this is what is published in the proposed rules at the moment. So that's the information that we're putting out. Next slide. So the quality program replaces the physician quality reporting system and the quality component of the value modifier program. clinicians who choose to report the 6 measures versus the 9 measures currently required under the quality reporting program, you can do that here. Reporting in this category accommodates for the differences in specialties and practices as well. Not too much more to elaborate here. Quality can be raising. It could be as simple as maybe decreasing on the readmission rate or no-show rate for appointments, things of that nature. And you'll see a list of those also in the Federal Register as recommended activities and also in the final rule. Next slide. Advancing care information accounts for 25% of the total. And it's going to be the same through 2019. We don't have any information of any changes for the years after that. But of course, documentation is always changing and being updated. Next slide, please. So the Advancing Care Information replaces the Medicare EHR incentive program, which most of you know is meaningful use. And I'm sure that's near and dear to your hearts. So the question might be, do I have to satisfy meaningful use and also advancing care information? Well, they're one and the same now. So you can report your customizable measures to reflect how you use your electronic medical record and the technology in your day-to-day practice to support interoperability and the information exchange. So if you notice, it's the same components that you would do under meaningful use, but now it's grouped together under the advancing care information portion. Next slide. And that brings us to the alternative payment models, which we'll get into in just a second. I try not to get through this information too fast, but I really want to reiterate the fact that we're not delving into the scoring because it would take entirely too long and it's too complex. So I would encourage you to take a look at that information and the proposed rules. And of course, in future webinars, we will come back with that information and we will allot time to walk through it. So as we look at the advanced payment models, next slide, we see that there's a shared savings program track, statutorily required demonstrations where clinicians accept both the risk and the reward for providing coordinated, high quality and efficient care. So it's not a situation where you can say that I've done it. They're going to require you to submit documentation that proves you've done it. You have to meet the criteria for payment based on quality measurements and the use of your EHRs. The criteria was designed to ensure that primary care physicians have opportunities to participate in the advanced payment models through medical homes, because typically your primary care physicians would not be eligible for the advanced payment model. But because of the medical home model, it gives them the opportunity to take part. Next slide. Okay, there's obviously criteria that one must satisfy to become an APM. And there's a list of models that qualify here. One is the comprehensive end-stage renal disease model for large dialysis centers and organizations. And then you have the comprehensive primary care plus model, the Medicare savings track 2 and 3, and then next generation ACO model, and of course the oncology care model, two-sided with the risk arrangement. And that is available in 2000. That's coming in 2018. Next slide. CMS obviously plans to update the list of qualifying APM models on an annual basis. Now there may be an update to these models that comes out in the final rules based upon the comments that they've received during the open comment period. I know they're intending to modify them in the coming year and to help others qualify to participate in the APM, so they'll be working on some things from the qualifications category as well. In the performance year 2019, clinicians could qualify for incentive payments based on participation in advanced APMs by non-Medicare payers, such as private insurers and state Medicaid programs. So when we go back, we didn't talk about it, but when MACRA was conceived, this was one of the things that they wanted to be careful about, and that was that they weren't seen as forcing private insurance to follow their payment models. Every one of us that have been involved in healthcare knows CMS always sets the floor. Whether intentionally or unintentionally, everyone always follows that payment model to do the initial framework for their own payment models. So you're going to see your non-Medicare payers gravitate to this model. Number one, because of value-based reimbursements and all of the other programs that are lining up under the MIPS, it actually helps the non-Medicare payers and providers get in line with the rest of the industry. So you can look for this to change gradually. And in some cases, I believe United Healthcare already has a portion of this implemented and are moving more toward the Medicare reimbursement model for value-based reimbursement. Next slide. Okay. This is the key here is that all clinicians will report under MIPS for the first year. And the reason for this is that is where it will be determined if you've met the basic requirements to participate in the advanced APM track. Now, the rule provides flexibility and makes it easier for clinicians to move from one model to the other. So you can go from MIPS to the APM track and back again, depending on certain criteria. Now, there's an example at the bottom. I'm not going to read it to you, but basically what it says is if I am in an advanced payment model and for whatever reason I do not meet the requirements or my reimbursement would be less based upon the data that I've submitted in that category. However, I have exceeded what I would have if I were under MIPS. I can request to be evaluated and reimbursed under MIPS. Next slide. Now, we've gotten through this a little faster than I thought we would, but that'll just leave us more time for questions. So in summary, CMS is going to begin to measure performance for, I say doctors, we'll say doctors, providers, other clinicians through MIPS, January 1st, with the payments based upon these measures beginning in 2019. Who is eligible? Physicians, physician's assistants, nurse practitioners, clinical nurse specialists, certified nurse anesthetists, and groups that include such clinicians. Next slide. Okay, the new quality payment program combines three of the programs that we all know into two. One is the merit-based incentive program, and the other is the advanced payment models. I would really encourage you to pay attention to the advanced payment models in the respect that the calculation for points can be very, very hard to understand. So you might want to spend a lot of time going through that material to see if you would want to qualify for an advanced payment models. Obviously, there are advantages. but you really need to understand how those points are calculated. Okay? The law requires MIPS to be budget neutral. In the first year, there should be negative adjustments, and you can't be any more than 4% in either direction, positive or negative, with additional bonuses for the highest performers. And MACRA seeks to enhance the shift to value-based reimbursement. That's the entire key. MACRA and all the components underneath MACRA are pushing value-based reimbursement. So if you are in this category, in the category of the physicians and clinicians that qualify for MIPS, and you are hedging your bets and you're not quite sure you want to move to value-based reimbursement, this program pushes you in that direction and helps you to get there based upon the things that are put in place and the measurements that you are required to meet under MIPS. And I believe that is our last slide, or do we have one more?
It does look like we got one more.
Okay, Scott, go right ahead. Okay. And of course, MACRA is the pathway through which eligible clinicians can become qualified participants and earn statutorily specific incentives for participation in the advanced APMs. Now, APMs, in order to qualify, you must meet basic requirements. First, you've got to use a certified EHR. Payments for covered professionals must be based on comparable quality measures. And you must be an enhanced medical home or bearing more than the normal risk or loss to qualify under this program. And there's lots of literature out there, and I believe our last slide, our very last slide, is a road to MIPS, which gets into a little bit more detail or gives you a quick overview of each one of the steps. And then on the very last slide, I've included some links that you can go to find out additional information on each of these areas. And I'm sure there will be more published over time, more than you'd ever want to know. I will caution you that if you go to the Federal Register and you decide to read it, it is not the most exciting reading in the world, but it's certainly worthwhile. You certainly need to understand what's being proposed there, and you can compare it to the final rule when it's published on November 1st. And I thank you for participating, and now, Scott, we can open it up for questions.
All right. As a reminder, if you would like to ask a question, please enter that question into the question box within the GoToWebinar app. Looks like we do have a few.
Okay.
Can you speak about APM and can you speak about APM and MSO connections? MAO connections. I'm sorry, APM and MAO connections.
Okay. Is there a specific question about the connection between the two?
You know, if Marta, if you can enter a follow-up question, maybe with a little more clarification about what you'd like to ask, we can get that asked. We do have a few other questions while we wait on Marta.
Okay.
That question. First question is, will providers with advanced EMR adoption lose out on credit in the newly renamed Meaningful Use Performance category, Advancing Care Information?
No, they will not. As a matter of fact, CMS has made an adjustment in their scoring to account for that, and they will not be penalized, and they won't lose anything by switching.
Okay. If the organization already provides telehealth services, will that count towards the CPIA category?
Yes, it will count. However, you can do things to earn extra points if you can make modifications or advances in the current telehealth system that you're using. Maybe you reach a different audience or something of that nature. That'll even get you more incentive points or move you toward the max.
Okay. How does MIPS under macro relate to the Secretary's goal for tying payments to quality and value?
It actually is a direct connect. The main tenet of MACRA and MIPS is supposed to be to increase the quality of care and to move us toward value-based reimbursement, with the patient actually being the recipient of all of this good stuff. So if you read the Secretary's goals, the programs that are put in place are supposed to move us directly toward her goals. So there is a direct connect there. I know there's been some comments from some of the different specialties and some of the other providers in the community that have said they're not on board with it. They think it's going to do more damage than good. But like anything else, I think we need to try it for the first year and see how the reporting turns out and how people are actually reimbursed. You won't be negatively affected in the first year, obviously, but you could end up on the positive side, at least at 4%. And then going forward, like any program that is put in place by CMS, it will require some refinement. So even though we reach November 1st and the open comment period is closed and we have a final rule, I would encourage anyone who has follow-on comments to still communicate those with CMS, and the Secretary will be looking at those things and they will further refine the legislation as we go along.
What are your recommendations for what an organization should do to prepare for MACRA implementation?
Well, there are, I would say, probably 5 things you can do. The first thing you can do is to educate your organization, particularly the C-suite. And the reason I say that is because of the financial impact that MIPS will eventually have on the organization and reimbursements. The second thing I would do is to estimate your MIPS score using your current meaningful use and your PQRSs and your VBM scores, so that you know where you sit right now. And then thirdly, optimize your meaningful use in your physician's quality reimbursement systems and VBM and quality to maximize the MIPS score, which will comprise of 75% of the 2017 MIPS score. So if you pull all of that together and you actually look at ways to maximize those things, like your meaningful use and so forth, that goes a long way to getting you ready for MIPS. The fourth thing I would do is evaluate your staff and your resources and organizational structure. Combine meaningful use and your physician's quality reimbursement systems efforts under one leader instead of having them going in 2 different directions. Or if you do have 2 people in charge, make sure they're working closely together so that the goals are the same. And then I would identify the deadlines impacting MIPS and the Medicare Shared Savings Programs for tracks 2 and 3, for the ACO, the NCQA, and application deadlines, and the MIPS exemptions or points, for people that are coming into the program in the middle. Like one of the things we didn't talk about is who is exempt, and of course any physician that joins Medicare or Medicaid programs after the implementation date, you're exempt for that year, and then you would qualify during the next reporting year.
Okay, Marta did re-enter our question. It says, looking for development of our value-based reimbursement program at a Medicaid managed care insurance organization, what steps should an organization take in developing a business model to be an APM?
Okay. Well, we almost talked about that. Well, we did talk about it a little bit here, Marta. as we were talking about the steps that you could take to, to get yourself ready for MIPS, you won't be able to obviously join or be an APM in the first year. So obviously what you're going to want to do is to make sure, number one, you use IT to gather all of your pertinent data to report on the MIPS. You want to maximize in each one of those categories that you can. And once you've met that threshold, you look at the qualifications, the characteristics rather, for to volunteer or to, not volunteer, but enroll or become an APM, and make sure you meet those qualifications. Your business steps or project plan, if you will, should guide you in that direction. And if you have some, what we call measurements along the way to make sure you're progressing in that direction, you then, at the end of the reporting period, could request to participate as in an APM. Does that answer your question? Specifics, because I don't know your organization, but the steps to qualify are going to be exactly the same.
All right, we'll see if she enters a follow-up question, but we do have one more. It says, is macro better than what doctors currently have to put up with regards to PQRS, meaningful use, and value-based modifier programs?
Well, I would say yes. If you look at the way it's streamlined, that's what it's supposed to be. Now, we're going to have to wait until the actual reporting comes out and reimbursement starts to give it the final approval, if you will. But on the surface, it looks like it should be better than what we currently have, because right now physicians are scattered all over the place in terms of qualifying for this. You've got, your quality payment program over here. You've got medical modifiers, so forth and so on. This is at least an attempt to combine things and make it more streamlined so you can look in one direction. And hopefully it will make it easier for them.
Okay, Marta did enter a follow-up question. It says, for organizations that would like to pursue an APM, do they first need to pursue MIPS activity initially, and is there any way to bypass the MIPS and go straight to an APM?
Okay. The answer to the first part of your question is you have to participate in MIPS first. There's no getting around it. And no, you cannot go directly to an APM. And I'm trying to think of the rationale behind it. And the only thing I can come up with is the fact that they want to make sure you meet the base requirements first before and you're looking at your reimbursements and so forth, and then move on to the advanced APM. Now keep in mind, even if you move to the advanced APM and your reimbursement or quality scores do not go according to plan, you still have the option to move back to MIPS and qualify under MIPS. Now, if you don't meet the thresholds of MIPS at that point, that's when, you start with the penalties and so forth and so on. But you will not, just to do a summary, you cannot go directly to an APM. You must, all organizations that participate must go through MIPS for the first year.
Well, Freeman, that is our last question. I really appreciate you serving as our speaker today for the CSOHIMSS Lunch and Learn webinar series.
Thank you very much, and I'm sure, as you had said earlier, we will make the material available in a couple of days for folks to go in and take a look at it. And by all means, if there are follow-up questions, I would love to entertain those. And thank you very much for having me as your speaker today.
And with that, I would like to thank all the attendees for signing on today. Handouts are available on the CSOHIMSS website right now. This session has been recorded and will be posted in a day or two. Again, thank you all, and we'll see you next month.